Professor Pietra Lampertico, the head of the Department of Gastroenterology and Hepatology at the University of Milano, Italy. I've been involved for many years in the research field of hepatitis B, antiviral treatment, natural history, management of naive patients, of drug-resistant patients, and recently we have also been involved in studies looking at new therapeutic options for both hepatitis B monoinfection and hepatitis delta B co-infection. We have been cooperating for a long time with Gilead Sciences because Gilead Sciences was one of the top pharma company working in the hepatitis B field. Because of this company, many very good drugs have become available, not only hepatitis B but also in the HIV. For example, for hepatitis B, adefovir at the beginning, and then TDF, tenofovir became available. This became available in Europe almost 10 years ago, and now a new drug called TAF is now the new drug available for hepatitis B. So this is the reason why we've been collaborating with Gilead in the last almost more than 10 years, really. In terms of HARVONI, it's one of the leading therapeutic strategies for hepatitis C. Has been available for some time in Europe and also in many other countries. The duration of therapy is related to several variables. For example, treatment naive or treatment experience, with cirrhosis, without cirrhosis, and very important also viral genotype. For some indications like genotype 1b, naive, non-cirrhotic, 8 weeks can be used. So very short-term antiviral therapy, very highly efficacy, with a very favorable safety profile. This has been achieved in registration trials, but also in a large number of real-life studies. For other conditions, 12 weeks is another possibility, and very selected situations you could extend and eventually add ribavirin in patients with cirrhosis or treatment experience. In terms of the cost, in Europe the cost depends upon each single country. For some countries it's very expensive, for other countries it's quite cheap. In Italy, for example, there's been a very favorable agreement between our government and Gilead Sciences. We were able to reduce very much the price, probably the best price in Europe. And this is the reason why we have been treated many patients in Italy, actually the larger number of patients compared to all the other European countries. And now we have developed a national plan for therapy and eradication of Hep C, and we are treating something like 80,000 patients every year in Italy because of the low cost of these prices. There is a strong link between Hep C and cirrhosis because at least in Europe, 70% of the patients with cirrhosis have chronic hepatitis C infection. In other countries, in other continents like Asia, Far East Asia, this is not true. Only 20 to 30% of cirrhotics have hepatitis C infection because most of the patients have hepatitis B infection. So the most relevant cause may be changing, may change according to different countries. Long-term chronic infection may lead to some of the patient's cirrhosis, and this is generally occurring at the late stage in the older patients population. Can be compensated, can be decompensated, but generally speaking is always a very severe disease that can be further complicated with liver cancer, which is the most important complication or decompensation, and these two complications really may lead to liver-related death. In Europe, basically, we are not using generics because all the branded names are available in most of the countries. Many countries, including Italy, the cost is rather low. And all these drugs in Europe are provided by the government, so they are for free. So there is no need to look for generics. However, I'm aware that the situation is quite different in other countries. And I also know that generics have been produced by many Indian factories or companies, and also in China. And there is a very recent study from Australia where they look at patients being treated with generics that were purchased in China or India. What they did in Australia was to get the drug for India and China and check the composition of the drug. And after checking the composition, they started to use the drug in the patients. So if you check the composition and then you treat, then the results were very, very good, superposable to the branded names. So the problem with generics is that we have no control of what's inside in each pill. It's not easy to check the composition of each pill. So you might have generics very similar to the original branded drugs, and these will do very well. But in contrast, you might find generics with very either little amount of acting compound, and this is probably might explain some data from Central Asia suggesting that patients for Hep C, treated for Hep C with generics, have a high rate of relapse, which is something that we don't see with branded names. So I would say we have to be very cautious, because if you use the wrong generic and then you have a relapse and you develop resistance, then you might become resistant even to the branded names. The reason why we are running randomized control studies is because this is the best way to define the efficacy and the safety of a new drug, and also the only way to define the best strategy in each individual patient according, for example, to genotype or disease severity or age or comorbidities. And it's the only strategy to define whether the new drug is better than the current drug, what we call the standard of care. And there is a lot of statistics behind these studies in terms of sample size and assessment of the final results. So these studies provided very important information in terms of efficacy and in terms of safety.